So here's what I want to talk about today. mHealth and all of its various, forms, including wearables and lots of things. We've been looking at it as if it's really going to be the answer for vulnerable populations. We talk about people living out in remote areas. We talk about people who are poor. We talk about racial and ethnic minorities. Well, I'm starting to get concerned that some people are really being left behind. So I'm going to have, these are my themes that I'm going to talk about, which is doing good for those who often need it the most, but how not to be a part of the disparities problem. My second theme is this is a vulnerable population, not the hard to reach. So if you want to see my next spin, like in, the movie, it's like, talk about hard to reach populations. No, they're not hard to reach. You have to really learn how to do that. I was actually asked to talk, there's a conference called Hard to Reach. I said, when you change the name, I'll come. But before that, I said, I am stigmatizing people along with you. So I don't want to do that. As I said, they're not from Venus nor Mars, so even though maybe that's a great place to be from now, but it's like it's a vulnerable population. We're going to learn what a vulnerable population is so that you're going to be the ones who will be very successful at getting them. Now, this, I know that Vivek and Bonnie and others put like ethics lecture, mHealth for all means not leaving anyone behind. And sometimes we put profit before we put people. And so we build something and we say, this will work, but did you think about who it isn't going to work for? And is that really the group that needs it the most? Whoops, sorry. So when we talk about doing good for those who often need it the most, there's actually a, inverse care law that talks about this, meaning that what happens is that people with the greatest healthcare needs often receive the least healthcare services. But it's interesting because we get very caught up in trying to ensure they get it, but we don't pay attention all the way through. So this is a problem that I want you to think about early in your design, not when you're trying to implement it and you don't get enough people showing up, not when you're trying to scale it up and then you start saying, I have to tweak it and things like that. But at the stage of the design is when I really want you to think about who's there and who's not there and what can you do. Typically, some of us take this, well, if we build it, they'll come, and it's like, well, maybe in years previously that would work, but you're going to see there's some special things about mHealth that make some vulnerable populations very nervous, like, data protection and, who it is that has access to this and you'll see, I don't want to give it away. So what you need to think about is that quite often, particularly in terms of our app development, what we're doing is we're trying to deal with a condition. We're trying to, in an individual, usually, not a lot of them are population health, but they're really about an individual. But what you have to remember is that diabetes or that HIV or that, pregnancy issue, it comes cast in this structural domain in which if you don't think about those, you may have the perfect person intervention, but the person cannot perfectly use it because of chaos and all the things that come up in their life. So I now often try and tell my team, does it work not just for the person, but and I'm going to show you some slides where, it kind of goes further out. Now, tell you kind of some of the populations that I've worked with, and none of these are easy. So we have one study in which we're doing Koreans who are 14 to 18 years old, and we're doing Koreans that live in an ethnic enclave, which is Koreatown, and we have a smoking cessation app, and we have spent years not pushing the app out, but understanding all these dimensions of culture and how culture is maintaining smoking. Because California is very successful at smoking cessation, but all the policies and all the activities, they haven't worked, and they have really missed understanding culture. So I was telling Vivek that we have to design things first so that we have credibility to get them to do the pickup for us. So, and I'll show you how in some other studies, credibility is really important. And you underestimate it. It's not credibility with the few people that you want to reach, because you're going to see in recruitment that when you lack credibility with a broader group, it slows your recruitment down. Okay, why did I say we're leaving people behind? Look at this. This is ridiculous. We're up here talking about what's on Mars and, celebrating all this work we've done. And what do we see? Wearables haven't solved the problem yet. New ideas are coming. Fitbits may not accurately track heart rates in people of color. And the interesting thing is, what you will see in the primary care setting or the specialty care setting is they're often saying to them, rather than having them walk around with a Halsted monitor or something like that, they're like, get a Fitbit and then give me the information and we'll make a decision. And the healthcare providers don't realize that Fitbit may not be as accurate as it should be, nor do the people of color who are using it, who vary in terms of skin color. See, I said, well, what's dark? Am I too dark or am I in the middle? I don't even know for me. Who doesn't have on a Fitbit? Me. So, because I don't want to start worrying and tracking information, then find out it's not working very well. So I have other ways. But here is what is unacceptable to me. This first came up about Fitbits, and I have no idea why they called it the Modern Negro, but it was on a black site, so it's kind of okay, but they did it that way. So you had to be in the in group to not be insulted, but I'm putting it on the slide because I want you to understand. So black people were ringing the bell talking about the fact that in 2015 that there was a problem. Then it comes up again, and it's like 2016, 2017. It's there now. You can't tell me we can't solve this problem. And you also, if you were to go through that, you see no service use agreement, you see no qualifications. It's like, I know one person, when I told him about this, he said, I've been through 3 Fitbits already. He says, and they didn't seem to work right. He says, finally, he used a monitoring from, that he was given by his healthcare provider because it was like he really needed the data. So don't leave people behind. Okay, I want you to understand, what does it mean to be socially vulnerable here? We're talking about differences and privilege. We're talking about power differential. And we're talking about the social context in which that individual lives in terms of their lived experiences. These vulnerabilities, they're not built into the person, but they impact and for the person are a function of, do they have social opportunities? Can they network with patients like me? Do they have the ability to be able to do these things? Economic resources, their social status, social capital. Social connectedness is very important for, some of these interventions to work. Is your person off by themselves or do they have a network? And you'll see where it's going to make a difference. And then, of course, there are policies of inclusion, exclusion. Well, if everybody's sitting in, if you have a population like in African Americans and Latinos, where most of the, a large percentage of the men are incarcerated, that's different. You have to then say there's an exclusion that's going on there. So when we talk about doing good for those who need it the most, we have to say, what are the factors that are going to support us in achieving our goal? So we're looking at the word support, maintain, create, and sustain that individual health condition that you want to change. That's why, to some extent, I think you have to take the social determinants model and start looking at, what is it that is causing that behavior to be there. A person comes to you and says they want to lose weight. They get EBT card and they don't have a store. I mean, so you have to understand, you're telling them to go do something that makes it very difficult for them to do. It's not about motivation. It's not about behavioral economics. It's about their ability to be able to do this, and that's what you have to plan. So in your design, you want to understand the flow of how they behave. You want to understand kind of the context in which it occurs. Particularly, sometimes I tell people, when you think about building an app that's on a phone, you better understand how that phone is really used. You assume the phone is their phone. And yes, the phone is their phone. But the little kids have the phone as the babysitter. The phone is like the cousin doesn't have a phone and borrows it. So, there's certain behaviors, like for our Korean adolescents, we had to put a whole little fake thing there so that, because their parents would take their phone in a heartbeat, because usually the parents don't really have, smartphones. Parents have dumb phones, as we call them, but they usually don't have smartphones. So certain things they want to do, they take the kid's phone to do it. Or they tell the kid to look on something and tell them to hand them the phone. So we were like, ooh, we can't put this smoking app on here. And it said smoking app or, some smoking thing. So we had to have a screen behind a screen. It cost us more money, but, it's one of those things that we knew we had to do because we studied how many people touch their phone, how is their phone used. So now they're like, fine, they'll give them the phone because they know you can't find it. This is, I don't know, is Dr. Rivera here this time? Oh, hi. Oh, there you are. Yes. I love this. He presented it and one of the things, and I love it. And the reason I love it, because I'm going to, kind of use it for something else, is look at how well that this side has been laid out. And then he even has over here kind of the more dynamic modeling of it. If you could think about using this and adding, for example, the social determinists as well, we would be just in heaven in terms of, I think, your ability to be able to have effective interventions. So here's one. This is mine. Looks crazy looking, but you're trying, let me go back here. You're trying to modify something down here. And just like he laid out the individual behavioral side, I'm trying to lay out the contextual side. And this has looked very busy, but I'm going to tell you, this is an exercise that in my lab you have to do. So when you tell me you want to do something, I tell you, go through and tell me all the kind of social determinants that are related to it. And then after they lay that out, see, the trick now doesn't work. They all know now. I used to say, now lay all those out. Let's learn about it. And I was like, and can we fix any of this? And they go, stop dead in their tracks. I was like, no, don't worry. I want you to think about and pick the ones that are most likely to show this, to slow your intervention down. So it might be the fact that the person is or is not married. Maybe we need a source of support to get them to do this behavioral thing that we're thinking about. It's like, somebody needs to nag them. Are you following the app? So you have to kind of figure out how having or not having these things will also be an issue in terms of that. So, again, it's like think about is the relationships between the individual level factors, the relationship between area factors, the relationship between the health outcomes. These are all part of your planning. And to try and remember that people behave, even though they're an individual, they behave in the context of things. Your context might be the healthcare system, your context might be the neighborhood, the context might be something else if the behavior you're trying to change has a lot to do with stigma, or it has to do with breaking norms that are in the community. We learned this very well when we were doing HIV/AIDS about that. Okay, so I bet that some of you are going to do some of these. These are usually the big ones, and you want to hit the jackpot, and you got them. So these are some of the big priorities that we have. Okay, I'm going to ask you a question now. Thinking about those big priorities, and you think about what it is that you wanted to do. So, I thought I had put this on animation. So the first question is, in building your app, which of the previous chronic diseases has the largest burden of addressing culture if that app is going to be successful? I even let you see it again. So what I'm trying to ask you now is, if you were building an app to change behavior in a vulnerable population, and these are the areas, which of these do you think that there is some cultural issue that you really, if you didn't attend to it, it's probably not going to be successful?
All of them.
No, this is like class where we do an exam like, no, all of them answer. I want you to really rank these, and I really want you to think. I want you to think about social support. I want you to think about maintenance. I want you to think about stigma. I mean, I could even pick a population. Okay, I'm going to give an answer. And you can argue with me about these answers. And if you argue with me about these answers, that's actually good. I'm one of those kind of professors. Oh, you can argue with me because I can argue that. So I'm fine with it. But for what it is that we're thinking about, if you were talking about, for example, the population of African Americans, obesity and weight management, cardiovascular risk factors, that stuff is on TV. Most of that stuff is like fine. When we talk about diabetes, it's almost like, people expect people in their family are going to get diabetes. Now, when it talks about obesity and weight management, there is a factor that is here that is not often talked about, but is one of the most complicating factors for getting particularly women of color, depending upon what their culture is, to follow a prescribed weight management program. And that is closeness to their racial ethnic group or their racial identity and body image. So, for example, you ask an African American woman to do weight management, and if you have not taken into account cultural perceptions about what an okay body image is, which Black women with a little more weight on who are heterosexual are like, I can't get down there too skinny, my man won't like that. Racial identity is about certain kinds of women and how those women look and what that means. We could do this with there's several populations in which we could do that. I kind of thought you might say it's HIV, but actually that's probably second. But the racial identity issue in this is important because it's very hard to get support if you're in a heterosexual couple in a family and you've got a guy who's really undercutting this, because it's like, oh, hey, baby, it's like, come on. It's like, I know you got to get some of this down, and I know we got to get healthy, but don't go too far with this. So racial identity or closeness. We have some other studies in our center about mental disorders and other stuff where, for example, it takes longer for a Latina to get into primary care services, mental health service, because their families will want them to go through the priest first. They have a route. So if your family is going to be in the middle of this, they have what they think is the way to do this. So we're starting to look at how close a person is to their racial group and what that means. Okay. Now, if I asked you again in terms of building these apps, it's part of what you should be asking questions about is, what is the age group we're talking about, the gender, the income, the zip code, neighborhood, geographic indicator, and as I said, race and racial identity. So I highly encourage you to include that as one of the factors that you want to consider for the uptake of your design. Same thing. So if I'm going to do mHealth and it's in the area of mental and behavioral health, suicide, bullying, mood disorders, autism, and you say, well, which of these is likely, for example, to have the most cultural needs in terms of building it? And it really has to do with, for example, suicide and suicide ideation, because there are racial and ethnic groups for which this is a religious problem. There are groups for which women doing this and they have kids there to take care of, it's seen as very unacceptable. So, okay, that was just, again, it's just kind of the same thing. So if you were doing the mental health side, what is it that you would be worrying about here? You would be worrying about, first of all, how much stigma is associated with this disorder, if you were trying to pick one of those. So are you in a community where they talk about autism a lot? Are you in a community where you cannot talk about suicide? Also, the support system. For mental health, you really need a support system in place once the person is, no longer under some kind of protected status. So you need to be able to talk about it. You need to have people go to people. So if they're not in support groups, there's nothing around, you really got a problem. We worry about that. And also, we say, like here at UCLA, and they're building all kind of things for students in mental health, and it's like, let's do something that's an app. Well, I hate to tell you, in the community, there's still this issue about privacy. And every time you hear, Facebook did this, something else did that in terms of data breaches, your populations are the ones that feel they have the most to lose. So you have to kind of think about that. Cultural belief systems about the disorder and whether or not there's a spiritual system in place. Because again, for suicide, these are all the things that are going to come into play. So these are things in your design you need to think about early on. So I'm going to talk a little bit about recruiting. There's a study, and there's the group, and you can find the paper and all of that, in which he recruited over 800 African Americans. This is in the Florida area. You have to approach us right. So that's one of the things to think about. And I'm not going to go through all of this, but because I showed you the article. The assumptions that you make about what you can do to get people in and where to go, you need to challenge yourself, because this research, my research, a lot of it is saying when you are doing mHealth, you need to think a little differently. So, okay, so for this, we're going to start out with word of mouth. Well, you can see the older the person is, the better the word of mouth. Not, you'll see later, not emails, not some of this other stuff, but they're neat, and see, you're going to learn the word credibility is important. So this word of mouth becomes good. Now, in the middle age, they might, do some texting, they might even use Facebook, but the older they get, that's not the case. And many of you want to do diabetes and some of this cardiovascular disease. It's like, you got to think about how you're going to do it. With males, excellent method, they say. Once you recruit me, then I can recruit my friends. So men are a little bit higher up even than women on this whole thing of word of mouth. Social media. So, okay, let's build this and see if they're going to come. And the issue is, the older they get, it's only a fair method. Middle group, very good. The younger group, excellent. And are there gender differences? No, they're pretty good for both. So, you just have to kind of see that here for the females it's considered fair, but here for the males it's like, we stay on Facebook all the time. It's like, really? Don't you have some work to do around the house? You're on Facebook? You and who? So, but you can see it's differently here. So you want to kind of know these things, in terms of your studies. Here, it's church. So people really kind of get me. Every time they want to do certain religious groups, we're going to go to the church. The church is a place where people's leadership positions, their status in that community are very critical. So you can't just go run to the church and think that they're going to say yes to you when they don't know anything about you. It can be good because it is a system, but as you can see here, concerned about credibility. If the pastor says it's okay, see, you've got to get through some system of, I'm going to check you out and see who you are. Because in a church, you start getting a bunch of people and something goes wrong in the study, it's like, oh, whoever, right away, who brought this person to us? And it's like, oh, they won't be chosen to be a deacon, and they won't be, I mean, you start to lose things. So credibility is really critical. Email, favorite things some people want to use. Nobody wants an email anymore. So you're emailing out all this stuff. At least when you talk to black people, they're telling you, I don't want an email. They believe some of these emails have all kind of mess in them, and you're going to mess up they don't know you. It's a white conspiracy. It's many things that people think. But as you can see, nobody is liking this very much. I heard about this focus group because someone I know from church sent me an email. So the church person could, but you can't. So you have to think long and hard about this. And this is the newest thing, particularly those of you who want to do these apps and, hair salons and barbershops. They just keep promoting this. You have to know what you can do where. And as you can see here in mHealth, it doesn't work at all. So for females, they just say it's a fair method. When many women and men go to these places, it's about catching up with what's going on. It's not, now somebody's gonna come in here and start trying to get me to think about something or do something. It's like, are you serious? This is my cultural time. Bye-bye. Don't come in here now. I'm gonna catch up. I don't read these kind of magazines and all, but somebody's gonna tell me what Beyonce did and Jay-Z and stuff that I half the time know nothing about. Groups who are singing I know nothing about. But in a hair salon, it's like, oh, if I just listen, I can walk out knowing more than when I came in. So it's not really a good place to do this. Even though you'll see that there are some studies now that are talking about people getting their blood pressure taken. That's because you're giving them something right then and there. But for you to come in and try and recruit from here doesn't work. So part of what we're doing is we're addressing and focusing in your design on this. And it's led by what this and this is. And I'm saying you have to think a lot about this. This is California Department of Public Health that did this. Okay, here's one of the studies that we did, which was on HIV. Okay, so you saw before my little cluster, my little risk cluster things where it was all those things that come together. Well, when we think about, for example, HIV, and what we're trying to do in terms of HIV, we start thinking about all these things as part of what's important in terms of, what we're going to set up in terms of reaching out to African American women. So what are the risks that we want to talk to them about? The risk isn't just the risk of unprotected sex. The risk is the risk pool, the men that are in the pool, and why the men may bring riskier conditions. And so we get a lot more credibility when we start telling you about these things. Oh yeah, it's like there's many people who have been in prisons and this and that. And so this works better as we try and think about like building these things. And so we have what we call, and other people have used this, I'm just giving you a slide, is this architect of risk. And part of that is you start here and you kind of stop here. We start here and we particularly pay attention to this, but we start paying attention to these things and asking how do we use them in design, how do we use them in recruitment, and will they be an issue, particularly in terms of scaling up. So we again kind of take this, and sometimes we say, well, before we release something, we need to try and change the norms. So in our adolescent smoking population, we're designing ourselves to be the go-to place for young Koreans that want to know something about smoking. So we have, I think it's 7 YouTube videos that we've designed. And it's like we're trying to get it to be cool to go find information, cool to think about changing your behavior, and to know there's a group. You want to do this? There's a group, and it's free. That kind of thing. So, again, kind of the doing good for those who need it most often. So you have to kind of think about. And I think I probably have said this enough that I don't need to. What is your group? What is the population it comes from? You're designing often for an individual, but remember what they bring. What modifies your group that you didn't include in your design? Is that you need to think about their culture, their neighborhood, their racial identity, whether they're US born, not, do you need, for example, to know something about the community culture? So we're trying to stop smoking in Koreatown, and there's very few places where they're not smoking. We were about to do something. We were like, oh, we don't even know any place to tell the kids to go to hang out that we know for sure will put them in a social setting where they're not exposed to people smoking. We have to go back in and look at that. Here are some of the things that people start to think about. Privacy, confidentiality, and security of data. As I said in our Korean app, we wanted to learn how do people use their phone, what kind of phones were they buying. We spent, I forgot how many times they went, but I had the students go and hang around the phone stores. And in the phone stores, we could see what did they want, what didn't they like about their phone, what phone was the most popular. So we start finding out what did they really prefer. And then we were even finding out, because we're in there just talking about stuff, as colors and all this other stuff. We used all of that as we, did our design. How do you think about this vulnerability in terms of the technology? So for example, here's what we learned. There are people who don't want their location revealed. Kids sometimes they don't want the parents to know where they're going, so they don't want things that leave footprints in that way. People who are, as I said, we have a study for people who is African American women who have uncontrolled diabetes. We didn't give them smartphones because a lot of them didn't own smartphones. So we give them phones where it's very basic. But what we knew was important was for the people around them to learn more about diabetes. And so what they do is we, give them the ability to load up pictures, to show them exercising, to show food choices and all this other kind of stuff. And that seems to be working. So we try to build and do what fits with what people are actually going to utilize. The other issue, and I see Nabil is here, and he can talk about this, is what happens when you collect data, especially if you're using wearables or cameras and stuff like that. You're collecting data from, again, as I said, you are focused on one person's health, but that one person is not isolated, and they may have a household in which there's mixed status in terms of immigrants, non-immigrants. There may be somebody who is on probation. There are all these things that are issues about people's data that are in the environment. And if you remember, those of you who are going to have anything to do with genetics, the community is really flipped out, because this probably was the telltale one where, what do you mean? How did the person didn't give their DNA, but it was a related relative. And so now, just like you hear about people going in the community telling immigrants what to do for the raids, people are having discussions with people about what happens in the collection of data and kind of the trails of it. So it's making it a lot more difficult. And the interesting thing is that it's who owns some of these. There's two really big African American databases, and they have actually had meetings with Rick Kettles and the other person about these databases, and under what circumstances can they be taken and all this other stuff. So you have to think about what that means. Again, the issue here is while there's all this great stuff about what these wearables were good for, but at the same time, they monitoring personal activities and physiology are likely to play an important role in managing health, to groups traditionally limited by socioeconomic status or remote geography. I don't agree with the remote geography, but we're finding that in terms of the SES, it may not be as good as we think it is. The special case, and I'm assuming since he's here, he's probably talked a little bit about this, but again, this is this issue of, what you're collecting may affect more than the person that you're collecting it from. Again, when we talk about this, kind of trying to do good, you have to kind of have a sense of whether or not when you're trying to use apps, there are things in people's system that, will kind of throw off your data. Is this a group who's likely to have their phone disconnected a lot? Is this a group who somebody borrows the phones? So all of this stuff you need to do. And a lot of the studies that show this stuff is proven are studies in which it's really tested out in academic medical centers where most of us are, instead of being in federally qualified health centers where it works very differently, kind of thing. And also, it's not that we lack the science to be able to put this into place. We don't have the fit to put it in our healthcare systems, particularly healthcare systems where they're federally qualified health systems. Right now, a federal committee that I sit on is trying to decide what the privacy rules should be about when you bring in data from your Fitbit or something to your physician, and your physician makes a decision. Remember, I just showed you that there may be a problem in terms of Fitbit. So we're trying to figure out sometimes they'll tell you, load this into your personal health care file. Have it in your electronic health records. Send me, after you've been to CVS 2 weeks in a row, send me your blood pressure reading. So this stuff is all being called into question because of accuracy and who's responsible for what. This I've kind of said. Let's talk a little bit about when you recruit your populations. You have to know who you're recruiting. When you use the federal government terms of Asians, Blacks, American Indians, etc., you won't know what it is that the issues will be if you don't then titrate down to know what the subgroups are. So if you were doing this in LA and it was very early, those were middle-class Blacks that were migrating here. So you can look at the age and see, and you just assume they're Black and they live in a certain area, so they're low income and all that. Not true. There is migrations of who's here. So one of the things that we know right now is a lot of the people who are being called African American in LA County, they're actually Nigerians. They're not African Americans in the US. Some will be born here and some have migrated here. That's going to make a difference. It makes a difference in terms of attitudes, behaviors, support system, cultural norms, etc. But if you just say, I'm recruiting Blacks, then you miss it. And the Asians are like, it's like night and day. You say Asians and it covers so many populations, which is why we've been very specific in our study about Koreans and things that are very specific to Koreans. If you approach us right, then again, you're going to find that it works. We did this. So here's what you have to think about. Ultimately, if you're going to not leave people behind, it isn't the same thing for everybody, but it's what people need in order to be able to benefit from the intervention. But and scalability is where this is challenging. But in the design, you need to, in the design, understand this so that you build it in a way in which in the design, you need to build it in a way in which it will do this. In scalability, it may be that, you decide based on greatest needs or something exactly what it is that you're going to do. So I'm going to stop here. I've talked enough. Let me take some questions. Yes.
Just from your gestalt of the data, do you think that the a lot of the things that we're doing with mobile devices, mobile apps, wearables are actually pushing away the populations from the socioeconomic status that are vulnerable. Like I have a feeling that that's correct, and you alluded to that. You think that data is very, very strong, and it's just getting worse and worse as technology is progressing, but getting more expensive actually to purchase.
Again, there are two ways to think about it. I think that the benefit and the ability to reach those who are younger and who are natives in terms of technology is an easier sell. But that's also the group that has the greatest knowledge about the distrust and mistrust issues. That's the group that is reading Root and all these other things that tells them about data breaches, etc. So you can get them, but your building has to be, and your recruitment, etc., has to be more about the credibility of what you have and the protection that you have. And I think you have less of the stigma issue. You just have more of the racial identity issue. When you get to the older group, I think you're right there in the sense of, as I said, in the center, our diabetes study, we don't use smartphones, just so that, we're not struggling with that. Yes?
So in the litigation world, there's been a wide discussion about sustainability. So for example, after the trial is done and the benefits are shown to populations that were in the trial and that could be vulnerable populations, can they afford the treatment afterwards? And so I was wondering if in the mHealth setting that discussion has already started, because I can see how, for example, we develop sensors, we develop algorithms, we develop all these things that could prove to be beneficial, and they could prove to be beneficial among vulnerable populations, but then is that sustainable? I'm just curious about your thoughts to whether this discussion has already started.
It's interesting because the discussion is much more the kind of research that you see Nabil doing, is that with wearables and data being collected, and sometimes, this is like people who have clinical health problems and, you're trying to have them wear something so data is getting transmitted and all this other stuff. And if you're kind of in a group where you're like, well, who's getting it? How do you know it's only that doctor's office? Am I going to get kicked out if I didn't walk this morning? Because you could come in and lie about whether you walk, but if you're now wearing a wearable and it's like, hello, Miss Jones, and they feel like you're looking all in my house. You saw I was in my bedroom. That's embarrassing. I mean, that actually is much more the discussion. I was involved in something where it's about a wearable, and people were like, I cannot have people peering in my house. I'm going to watch my soaps from this hour to this hour. This is an elderly woman. I'm going to watch my soaps from this hour to this hour. I don't care if they say I'm supposed to do this and this and that every so often. I'll make up the time. So the woman, and I was trying to translate to the PI, she's asking that it be done differently. Can you figure a way to work around the way she wants it done? Because otherwise she feels she's going to get a phone call, or one of the students, the way they were doing it, students were going to be bothering you. I said, and this young voice calling her up, I said, you'll be lucky if she doesn't curse the person out. So I don't, sustainability isn't where people are as much as they are with privacy, intrusiveness, and flexibility. And it's interesting when we start doing this, these things, it's kind of like, we want it every 2 hours, and it's like, come on, if you were giving them a drug and just sending them home, that there's some give or take, But then because we're collecting data, we're actually saying in a way in which you're bad if you don't do it exactly the way I tell you, and that you are like compromising your care. So, the group that I work with, it was like, you need to redo the script, you need to think about flexibility, you need to ease up. But it was the researcher side that was really the problem. It was less the clinical side. Yes. You need to tell me when I have to stop because I'm looking at my time, whoever is monitoring me. Go ahead.
So I'm from Johns Hopkins, and we have
You're in Baltimore.
Yeah. So we have a legacy of distrust in the community,
We do.
rightfully so, because there have been many bad things that have happened
There
at
have been.
Hopkins, with the community surrounding the.
And you've had movies even about
Yeah,
yours.
yeah.
So let's kind of say, I don't have to dig very far.
Right.
I can find black movies and just think it's interesting and then find out, oh my God, this was John Hopkins, so.
So I was just, and I asked this of people whenever, we have conversations about this, what advice do you have for overcoming that legacy of distrust when, you actually want to do good and almost make up for that history? How do you build trust in a community where there's so many generations of distrust? And it's almost become self-fulfilling because you have researchers who don't even want to put that work in, and so then it becomes, well, you don't want to work with the community, and so you're not even helping the neighborhoods that surround the medical institution.
There's short-term, long-term. I happen to be a visiting scholar at Tuskegee's Bioethics Center, and I can tell you, because I've met with the families of the survivors, what do they want? They want their kids to have scholarships. They want people to do things that, okay, you screwed up in the past, but how can I benefit going forward? It's just like, I hate to say this, but it's like, there's a reason reparations are being talked about. And it's like, don't give me an apology, but give me something that allows me to, for all that bad that happened and the people behind me didn't benefit, for me to be able to take it. So, for example, when I did my first HIV study, I cut a deal with the care center, and I said, you have to be able to take a few people in, in terms of treatment. And so, it's UCLA, we're not the biggest on wanting, well, now it's probably okay, but at the beginning we didn't want Medicaid and people who didn't have, but I cut the deal. I could not go in a community, do all this testing, and give them a diagnosis and say, well, you can go anywhere but UCLA. So I said, I talked to the university, it's like, you need to give somebody something. I have overhead, you need to do something because it's embarrassing. And I learned that real quick is, I offer you for the sins of people behind me, and often in a community meeting, I will tell you, I cannot do anything about the sins of the people behind me, but I'm the PI, so the buck stops with me and you can come to me. But this is what I can give you that is the institution's resources. So, and I think I probably need to stop.